Okay, look, if you're an OBGYN, a fertility fellow, or a practicing reproductive endocrinologist, you already know the textbook definitions. So, today, we're leaving the basics completely behind. We are diving straight into an explainer on advanced clinical decision-making, pharmacology, and troubleshooting in controlled ovarian stimulation. Based on Dr. Jude Adegi's highly regarded lecture, we're going to really look under the hood at the why and the how of IVF stimulation. I mean, we need to master exactly why we choose one specific protocol over another for a highly specific patient profile, and precisely how to pivot when you're right in the middle of a cycle.
So here's our clinical roadmap for today. We'll start with the physiological foundation, move into our pharmacology toolkit, discuss the core protocols, look at monitoring and adjustments, tackle managing complex cases, and finally, preventing complications. Let's just get right to work.
Section 1. The Physiological Foundation. Bridging endocrinology with clinical application. Our core objective every single day is essentially overriding the body's natural selection of a single dominant follicle.
Now, before we even think about writing a prescription, we're looking at our baseline biomarkers, right? AMH, AFC, day 3 FSH, and estradiol. But, and this is a big but, every single one of these metrics has its distinct limitations. Actually, you really can't rely on just one in isolation to perfectly predict how a patient's ovaries are going to respond.
And that data forces us to categorize the patient's phenotype right out of the gate, using frameworks like the Bologna and Poseidon criteria. We're putting them into buckets: expected normal, poor or low, and hyper-responders. Defining this phenotype isn't just some administrative box to check. It is literally the mandatory foundation before you even think about opening your pharmacological toolkit.
Which brings us to Section 2, the Pharmacology Toolkit, equipping the clinician's arsenal.
First up, gonadotropins. Right away, you're faced with a high-contrast decision. Do you go with recombinant FSH or highly purified urinary menotropin, HMG? As clinicians, we know this isn't just a flip of a coin. You really have to ask yourself, does this specific patient require LH activity? While RFSH gives you a super pure, targeted approach, HMG brings that absolutely crucial LH activity into the mix. And honestly, that can be the deciding factor in cycle success, especially depending on the patient's age and their ovarian reserve.
Next, we've got to achieve pituitary suppression. Here, we're stacking up GnRH antagonists against GnRH agonists. With an antagonist, you are deploying a rapid, competitive blockade of those receptors. It's fast and it's direct. But with an agonist, it's a bit different. You're strategically initiating an initial flare effect of endogenous hormones, which is then followed by a deep down regulation. So it's a fundamental choice, right? A rapid suppression versus a controlled exhaustion of the pituitary.
And finally, the triggers. This is your last pharmacological tool to induce maturation right before retrieval. You've got options. You can use HCG, which mimics the LH surge and has a dual action. You could use a GnRH agonist, which actually induces the patient's own endogenous LH and FSH surge. Or you can mix it up and utilize dual triggers. But the absolutely vital takeaway here: your trigger cannot be chosen in a vacuum. It absolutely must match the preceding protocol you've deployed. No exceptions.
All right, moving to Section 3, Core Stimulation Protocols, the Strategic Blueprints. And I want you to view these not as rigid textbook rules, but as highly dynamic clinical strategies, tailored specifically to those phenotypes we defined earlier.
Let's walk through this matrix. The short protocol, utilizing the antagonist, is basically ideal for normal responders and PCOS patients. Why? Because of its speed and the significantly lower OHSS risk. Then you have the long agonist protocol. This is your heavy artillery for endometriosis. It gives you excellent control, but yeah, you're risking cyst formation. Now, for poor responders, the microdose flare is a go-to because it boosts recruitment through that endogenous FSH, even though, let's be honest, cancellation rates are pretty high. And finally, the PPOS protocol. It's a cheap, highly effective option if you're doing a freeze-all cycle. But remember, fresh transfers are completely off the table with PPOS.
Okay, Section 4. Monitoring and adjustments. Navigating the mid-cycle pivot. This is where things get real. We are now actively on the battlefield of the IVF cycle.
When you're doing those ultrasounds, your eyes should be absolutely glued to one metric, 1.5 to 2 millimeters. That is your target daily follicular growth velocity. You track this every single day because it dictates whether you hold the course or if you need to make an immediate mid-cycle dosing adjustment. It's a total delicate balance. You are constantly interpreting rising estradiol levels relative to the actual follicle count. You're diligently monitoring for any sneaky premature progesterone elevation before giving that HCG trigger. And based on these hormonal trajectories, you've got to make real-time decisions to either step up or step down the stimulation dose.
But despite your absolute best monitoring, we inevitably face the most difficult and, frankly, the most dreaded conversation in the clinic. When is it time to cancel a cycle? Knowing exactly when to cut your losses to protect the patient, or even just save their resources, that is the true hallmark of an advanced clinician.
Section 5. Managing complex cases. Troubleshooting the extremes. Now it's time to look at the hardest challenges we face day in and day out.
The poor responder is incredibly challenging. While Dr. Agee notes there's really no proven panacea, there are several adjuvants heavily proposed in our field. Things like growth hormone, DHEA, and testosterone priming. Look, these are the strategies you deploy when your back is firmly against the wall and you're fighting for every single viable oocyte.
Then we have to consider the environment for the embryo. 7 millimeters. I want to aggressively highlight this measurement because an endometrial thickness of less than 7 millimeters is the universally recognized clinical cutoff for a suboptimal lining. If you don't hit that 7 millimeter mark, you have a major problem on your hands.
So what are your pharmacological pivots when that happens? Suggested rescue therapies include oral estradiol tablets to really push that proliferation, sildenafil tablets or vaginal cream to improve localized blood flow, or, if you're looking ahead to a future cycle, a complete change of the underlying ovarian stimulation protocol itself.
Finally, Section 6, preventing complications, avoiding the ultimate pitfall. Because let's be real, a great yield means absolutely nothing if we fail to protect the patient from our field's most dreaded complication, ovarian hyperstimulation syndrome, or OHSS. This brings up the critical question every single fertility specialist has to answer, especially when you're managing a hyperresponder or a patient with PCOS. How do we completely prevent OHSS before it even starts? Well, to prevent it, you have to remember the microscopic battle you're fighting. The pathophysiology of OSS is rooted in VEGF-mediated capillary permeability. Vascular endothelial growth factor causes fluid to just leak out of the intravascular space straight into the third space. That is the exact mechanism you are trying to shut down. So here is your actionable battle-tested checklist. First, use an agonist trigger to avoid the prolonged half-life of HCG. Second, utilize cabergoline. It's a dopamine agonist that directly inhibits that VEGF pathway we just talked about. And third, completely remove the risk of late-onset OHSS by doing a freeze-all cycle for the embryos. Just plan for an interval frozen embryo transfer later on once the ovaries have completely quieted down. So, as our diagnostic tools get sharper and sharper, how will individualized IVF protocols continue to evolve? Especially as we discover deeper and deeper nuances in patient biomarkers and phenotypes. The toolkit is literally always expanding. But if you master this foundation, you'll be ready for whatever comes next. Thanks so much for joining me for this explainer.